Hello, everybody. Welcome this evening. It's wonderful to see so many familiar names popping up in the audience list. So great to see you all. On behalf of the UVic Retirees Association and Institute on Aging and Lifelong Health, I welcome you to the 2023 Masterminds Lecture Series. As a settler on this land, I respectfully acknowledge the Lekwungen peoples on whose traditional territory the university stands, and the Songhees, Esquimalt, and Wasanich peoples whose historic relationships with the land continue to this day. My name is Leah Potter. I'm the administrator at the Institute on Aging and Lifelong Health. Our Health Research Center conducts and supports research in health services, populations, digital health, brain health, and behaviors and interventions to improve the health, aging, and quality of life for people across the life course. The UVic Retirees Association, also known as the UVRA, maintains and optimizes the relationship between the university and its retirees. With over 700 members, it is the largest association of its kind in BC. This is the 17th annual Masterminds Lecture Series. The series began in 2006, spearheaded by UVRA board member and past Dean of Education, Dr. Beverly Timmons, and then director of what was the Center on Aging, Dr. Elaine Gallagher. Since then, we've produced this series every year except for 2020 with the sudden onset of COVID lockdowns. We'll begin with Dr. Kathy Gaul's presentation in just a few moments, followed by a question and answer period. If you would like to ask Kathy a question during her presentation, please type it into the Q&A box by clicking on the Q&A icon on your Zoom screen. Questions will be moderated and we'll bring forward as many as possible during the question period. To confirm, as an audience member, your audio is muted and your camera is off. You won't be seen to anybody else in the audience. You can adjust the view of your screen by clicking on the speaker's window and moving it so that it's not covering your slide view. So if you find that the little box that has Kathy's image on it is covering a bit of her slide that you would like to see, just click on it and move it to a different spot of the screen. You can also add AI word-to-text closed captioning to your screen by clicking on the closed captioning icon. This event is being recorded and will be posted to YouTube and uploaded to the websites of the UVRA and the Institute on Aging and Lifelong Health. Audience members, such as yourself, will not be appearing in the recording. And now I am delighted to introduce Kathy to you all. I'm just going to make Kathy spotlit. There we go. Dr. Kathy Gaul is a Professor Emerita and exercise physiologist in the School of Exercise Science, Physical and Health Education at the University of Victoria. She taught courses in human anatomy and exercise physiology prior to retiring in September 2022. Kathy's research interests include the physiology of exercise and exercise medicine, with projects ranging from elite sport performance, occupational and pediatric exercise physiology, and exercise as an intervention for those with suboptimal health. Kathy completed her PhD under the excellent supervision, guidance, and encouragement of our very own Dr. David Docherty here at UVic. She considers herself exceptionally fortunate for being able to stay at UVic as a faculty member throughout the remainder of her academic career. In addition to being a faculty member in the School of Exercise Science, Physical and Health Education, also known as FE around campus, in the Faculty of Education, Kathy contributed to the development of the Island Medical Program at UVic, part of the UBC Medical School from before its inception. She took on responsibilities for the medical education curriculum and its delivery here in Victoria, as well as across the province. During this time, she was also instrumental at advocating for the inclusion of exercise being formally incorporated into the medical curriculum at UBC, and was the first exercise curriculum theme lead in that program. Post-retirement, Kathy continues to work on promoting the inclusion of exercise into the medical undergraduate programs across Canada. She has been the faculty sponsor for Exercise is Medicine Canada on campus at UVic since its inception, and has presented Exercise is Medicine workshops to healthcare professionals in BC. She is part of a team of Canadian colleagues focused on promoting practical strategies for the incorporation of exercise prescription into primary health care. Kathy enjoys being physically active and takes advantage of the extra time available to do it now that she's retired. When not working on manuscripts, curricular projects, and helping out graduate students, she enjoys hiking, working out, sailing, cycling, and traveling with her family. Her presentation this evening is titled, Exercise is Medicine, a broad spectrum prescription for all. Kathy, over to you.
Thank you very much, Leah, for that. And I'm just going to share my screen. So here we go. See if I can make that work. Please work. Here we go. Is that good? Can you see that?
It looks great, Kathy.
Great. And I have to just get rid of a few more things on my screen so that my slides are not. How do I get rid of everybody? Oops. Well, I'll live with that. Okay. Well, thank you very much and welcome everybody today. Leah has already done a really lovely land acknowledgement. And I just want to recognize that the traditional lands that I'm presenting on here in Oak Bay fall underneath that acknowledgement, and these are lands that I feel very blessed to be able to live and work and play on them, and I thank those who allow us to do that. Okay, my presentation today is right up there, and I'm going to start right off the bat by saying that I am biased. I believe very strongly that exercise should be part of care for all, whether we're healthy or sick. And it's something that I am very passionate about trying to improve the knowledge that our medical students gain as they go through med school so that they can be more informed as physicians to help their patients use it as a tool and as a medication to try to either prevent disease, maintain health, or use as a treatment. So that's what we're going to be talking about today. So I have, I'm just going to close this up. There we go. Just a quick overview of what I'm going to do today with you. I'm going to start off with a few little stats and some historical knowledge, very tiny, a little tiny bit of epidemiology to do that. I want to focus on the evidence that we have that exercise can be used very efficiently as a medicine. And I want to jump right into talking about the mechanisms. It's one thing to say that these things happen, but let's actually show you how regular exercise, being regularly physically active in a variety of different ways can be used as prevention, can be used to manage illnesses, or can be used to treat or enhance treatments. And I'm going to use a few different conditions to provide those or build that story for you. There are many that I could use, but I'm going to talk about cardiorespiratory fitness, development, childhood development, diabetes, osteoporosis, and cancers as my examples, but I could have used many others. We'll start there though. I'm going to spend a tiny bit of time at the end just talking about where do you get this exercise prescription and how can you implement it, and then a couple of quick comments at the end. So that's how I'm going to present over the next 45 minutes or so. So let's just jump right in here. Okay, so exercise is used, we've known this for a long time, that it can be used to improve the health of pretty much all of our physiological systems in our body. I made this little slide for tonight and then realized that there's a whole bunch of others that aren't represented here. This is just an idea of what you might be able to take from tonight's presentation that all of our physiological systems can be affected, from bone health to reproduction to skin health, strength and function, our immune system, our nervous system, mental health, cardiovascular health, cardiorespiratory health, cancers, other illnesses. It is a very broad spectrum prescription. That's what I'm really trying to get across today. This is something that we have known for a long time, and there are some pretty special people in our past that talked about this very early on, long before I was around. For example, Plato said that the lack of activity destroys the good condition, and every human being should take up movement and methodical exercise to save it and preserve it. That's a long time ago. So this idea that exercise is beneficial to our health and can be used as a medicine has been around for a long time. Hippocrates said something very similar as well, as you can see right there. And a little bit more recently, we've got Henry David Thoreau, who said, "Methinks that the moment my legs begin to move, my thoughts begin to flow." And I suspect that most of you that are listening tonight have experienced the fact that you actually feel better after you've moved around a little bit. These bodies that we have, although they don't come with an owner's manual, we know from our experiences that if we move the body in one way or another, we're going to feel better about it. And sometimes we feel really crappy, and the last thing we want to do is move. But in actual fact, if we can get that body to move even just a little bit, it's going to feel a whole lot better. And that's what we're going to be talking about tonight. So I'm just going to stop here for a minute. Leah, is there a way that I can get rid of I've got a whole list of presenters here and I just don't want to see them, and they're gone. Okay. Thank you. Okay, here we go. So let's talk about it from a prevention perspective first. Exercise as a preventative medicine. We can use regular exercise or regular physical activity to reduce our risk of morbidity and mortality, and that's all-cause mortality. We can use it to improve our health by just doing some kind of activity regularly. We're not talking about becoming an elite athlete. We're not talking about running marathons. We're not talking about lifting heavy weights. We're talking about using the body in a commonly regular way. If you want to get into some of the bigger activities, then you certainly could, but you don't have to do that in order to be able to cash in on the benefits of being regularly physically active. It's also important to recognize that from a preventative perspective, what we want from the very beginnings of our life is to grow optimally and to develop and optimize our development. I'm going to use the example of bone health as to bring that point home in a few minutes. We can also use exercise or regular physical activity to prevent many chronic diseases. In tonight's presentation, I'm going to talk about preventing diabetes and preventing cancers and some cardiorespiratory illnesses, but there are many others that we could use as examples as well. As a preventative medicine, there should be some kind of guideline, and we in Canada are very fortunate to have the Canadian Societies for Exercise Physiology, who as a group have put together some very important physical activity and movement guidelines for all the various ages within our communities, from young children to youth, adolescent and youth, to adults, right into older adults. And we'll talk about those guidelines a little later tonight. Generally, you can look at the benefits of exercise and health from a couple of different ways. The statistics that are on this slide show the benefits, or another way of putting it, the risk reduction that being regularly physically active can provide to us for all-cause mortality, for cardiovascular disease, for diabetes, stroke, a number of cancers. I've listed 3 here, but that list is as long as about a dozen. Alzheimer's and depression and anxiety. And all of these, if you look through here, you can see that's a pretty large benefit. It ranges anywhere from the high 20s to up to 60% risk reduction. That's pretty significant. There aren't many medications that you can take that will do that. Certainly proper diet, proper sleep, and maybe some vitamins, minerals, that kind of thing can reduce some of our risks. And sometimes some pharmaceuticals can do that as well. But we're talking about one thing that will do all of that all at once. That's a pretty impressive medication, I think. Okay, let's see if I can move on. So let's start with some evidence of this. I'm going to start with cardiorespiratory fitness. Most people think when they talk about being physically active or being healthy because of physical activities, they think about it in terms of cardiorespiratory fitness or aerobic fitness. Most of what I'm going to talk about today comes from a variety of different exercise studies that include cardiorespiratory or aerobic exercise, but also include resistance training, high intensity training, all types of different exercise. But since aerobic exercise is something that most people think about, I thought I would begin here because it's common, most people have some idea of what it means. What I want you to take from this graph is that up in the top where the blue line is, the blue box is here, these are people who have good cardiorespiratory fitness, so good aerobic fitness. And the ones in the lower lines here, they are the poorer cardiorespiratory fitness, so the lower aerobic fitness. And what I'd like you to note is that if you look down here, you can see that the thick lines are, so the thick line here, that's the normal weighted individual. And the thin line right here, that's the of an overweight individual or group of individuals or those who are obese. And down here with the low fit individuals, you can see that we've combined both the normal weight individuals and the overweight individuals. So the story behind this graph is that cardiorespiratory fitness is much more important for survival rate, that means all-cause mortality, than weight is. It's more important and it's healthier to have good cardiorespiratory fitness than it is to manage or bring your weight down. That's good news because some people have a more difficult time taking their weight down or managing their weight than others, or they manage their weight, but it's at a higher level. So I don't want to emphasize the issue of being overweight or obese today in our presentation, although that does play a role in some aspects of health. I want you to recognize the importance of just being able to get to a cardiorespiratory fitness, which exercise can provide for you without having to become elite athletes. Just doing something somewhere in the area of about 30 total minutes a day, most days of the week, hopefully at least 5 of them, doing something that has some weight bearing associated with it. And also doing something that provides you with some resistance work that could be weight bearing a couple times a week, and something that gives you a chance to challenge your balance and your stability. You're going to get to that point. Okay, well, let's look at bone as an example of tissue and a physiological system that's impacted by exercise right from the very beginning of our lives and through our whole lifespan. Now I'm into retirement now, so I'm getting old and my bones are not as happy as they used to be. I would like to have known more about this when I was 5 or 6 or 7 or 12 or 15, and I'll explain why in a moment. There's a couple of things around bone structure that you should be familiar with, or at least be aware of. This is the shoulder, and there's a section of your shoulder, and this bone here is the bone of your upper limb, and you can see that there's all this spongy looking bone in here. This is actually hard and it has little spikes. They're called trabeculae, and that's what they look like over here. And on the perimeter of all of this is a much more compact bone. It's this trabecular, sometimes called cancellous or spongy bone, that is most important in the development of strength and bone mineral density in our bodies. So if we're talking about development of bone. We want to be able to pack in as much bone mass into our bones, as much mineralization into our bones to make them as strong as possible as early in our lives as we can. And that's what this graph demonstrates. The red part is female, the blue part is males, and we're talking about biological systems here. So I'm not going to get into the gender issue in this presentation. I'm just going to talk about it from a biological perspective. So you can see in this graph that almost all of the males and females reach peak bone mass somewhere around 20 or 25. So between 20, 25, and certainly by 30, you've reached a peak to bone mass. This is like saying, after that, you can see that it slowly in males starts to drop off as we get older. And in females, unfortunately, it doesn't stay up there for very long and it starts to drop off pretty quickly, especially as we get into our menopausal years. And it drops off sooner and more precipitously in females than it does in males. What this means is that when you're in your teenage years, you want to be doing everything possible to enhance your bone mass accumulation, because after you reach the age of about 25 or 30, that's it. You can maintain it, but you can't increase it beyond that. Our physiological system doesn't allow that to happen. It just doesn't happen. So it would be like telling your teenagers, or the teenagers that you know, that they can pack as much money into their bank account as possible, but by the time they reach between 25 and 30, that's it. Their bank account balance can never go beyond that point. Well, for me, that would have been pretty horrifying. I don't know about you, but if I couldn't have had any more than what I had in my bank account when I was 25, I would have really struggled. And that's what happens with our bone. After that age, we don't gain anything more. We can maintain it, but we don't gain it. So what can we do in these early years to enhance bone mineral density, enhance the development of bone so that we can really get these numbers up, this peak bone mass up as high as we can, so that by the time we start to drop off, it's up as high as absolutely possible. We've optimized that. Well, there's some things that you need to know about bone in order to answer that question. Bone responds to the stress that's placed on it. This is a situation where stress is a good thing. It influences growth and it influences bone mineralization. That happens because certain bone cells, like they're called bone osteoblasts, are activated when there's stress placed on it. So if you're standing or you've got weight on your bones, if you're jumping or leaping, that kind of movement enhances bone mineralization because it activates those bone forming cells. It enhances the mineralization of bone, which makes it stronger. And that is controlled by hormones. And those hormones happen to be influenced also by being physically active. And as a result, we end up having much greater skeletal strength. And that strength comes from the mineralization. And if our mineralization has been maximized, then we're going to be able to last much longer with the skeleton that we have as we go beyond adolescence and into adulthood. And like I am now, into the older part of my adulthood. This has huge implications for exercise, especially weight-bearing activities. This is so important that NASA and the Canadian Space Agency and all space agencies in the world these days put a lot of effort into. We have a picture here of Chris Hadfield. You probably all know who Chris Hadfield is, or maybe Robert Thirsk, who was actually on campus for a little while a few years ago while as training as an astronaut. And this is an American female astronaut as well, and each one of them are exercising. This is on a treadmill. Notice that he's got bungee cords keeping him on the treadmill, because if not, he'd be floating off the treadmill and he wouldn't be able to run. Same thing in this. This is called the ARID. It is a resistive exercise device that's used on the International Space Station. and they're locked into it and they are pushing down or pushing up on, it's all hydraulic. And over here that Robert Thursky's on, this is International Space Station cyclergometer that they have. All of these have vibration isolation systems on them because any kind of movement shifts the ISS just a little bit, and that's bad news for the very, very delicate procedures that they're doing in their research. You'll notice that Robert here, he's not actually sitting on a cyclergometer, but he is actually cycling. He doesn't need to sit down because he's floating anyway, so he has to be harnessed in there. The reason why I have this in here is because if you don't have stress on bone, bone's not going to be maintained. And in space, including in the International Space Station, you've got very little gravity there. And as a consequence, they're floating around and there's no stress on bone. So astronauts, especially the ones that are up there for any length of time beyond a few weeks, start to see a loss in bone mass. And it can become a very significant loss in bone mass that is very hard, if not impossible, to regain. Those who are up on the International Space Station for a year or longer have very significant bone loss. And the effort that is put into trying to help them maintain that bone mass is obvious by these slides. All astronauts and the International Space Station have an exercise routine that they must follow every day. They put in anywhere between 90 minutes and 2 hours a day just dealing with exercise in order to enhance their bone as much as possible, in order to maintain their cardiovascular fitness, and in order to maintain their muscle mass, so that by the time they come back down to Earth, they haven't lost so much that they can't function. We've learned a lot about bone mass and exercise from the work and the research that's done in the International Space Station, thanks to these people and others. Okay, so bone strength. Bone strength comes from the microarchitecture that exists within bones, and that gives us the resilience and the strength of bone. And if you looked at these two little architectural structures at the bottom here, which one would you like to support you? I think it would be the one that had the most bars on here, because it would give you that architecture that manages strength a little bit more. If you lose it, then that bone becomes very easy to fracture. And you can see in this diagram here that the neck of the femur right here is looking as if it's thinned right out. And that's exactly what happens when you demineralize bone without stress on bone. The tuberculae become very thin and the bone becomes very brittle, and it eventually becomes much easier to fracture. You don't want that to happen. Bone formation happens because of a balance that exists between the resorption of bone and the formation of bone. And you can see that right here. This is resorption and this is formation. And resorption happens because we have these little Pac-Man-like cells that go in and break up bone so that it can be rebuilt. And then we have those osteoblasts that lay bone on so that we can form it. This is a balancing act. And with growth, we have a much greater amount of formation than resorption, and that happens prior to about 25 years of age. After that, we have maintenance, which is really a balance between resorption and formation. And as we get older, that formation slows right down. So resorption becomes greater than formation. Or if we get ill, or if we're on certain medications, it will impact formation and resorption will take over, so we become imbalanced. So this balancing of the remodeling cycle in bone is very important. And exercise plays a big role in stimulating these osteoblasts. And if we can get this side of the balance to be greater than the resorption side, we're going to get bone formation. So in adolescents in particular, we want them to be as physically active as possible with weight-bearing activities, so that in a regular routine, so that they can maximize their bone mineralization while they have a chance to do so. Because once they start realizing it's important into their 20s or 30s, that ceiling has already been set. And we want that ceiling to be as high as possible for them. And the only time we can do that is during adolescence. So we have this resorption and versus remodeling balance that happens, and you can see there's some nice healthy bone and there's some osteoporotic bone. And looking at it a little bit more closely, you could see this is not going to support very much, is it? We'd want something that is much thicker, these trabeculae to be much better to work with. So what if we have a suboptimal lifestyle? So not very much physical activity, more sitting around, not a lot of weight bearing. This graph is very similar to what I showed you before, but now I've overlaid what happens during osteopenia or osteoporosis, where we see a loss in bone mineralization. Normally in females, and this solid line is females, we get to a point somewhere in the late 40s or early 50s where we get this big increase in decline, and that's what we expect in menopause. But in individuals who at an early part in their life have suboptimal lifestyle or suboptimal activity level, you can see that their line here is much lower than what we would see if we had optimal lifestyle, and that would mean activity. If we fail to achieve optimal peak bone mass during adolescence, these numbers are going to be much lower. And as a result, you're going to reach this osteopenic or osteoporosis level much earlier. So we are down here now at 20 or 30 instead of being up there. And this is more noticeable in females, but it also affects males as well. So while we tend to focus on this with female health, I want you to recognize the importance it is for males as well. Young boys who are not very physically active and don't do much in the way of weight bearing are going to have their numbers much lower than the optimal value, which means that as they start to decline with age, they're going to reach this osteopenic level much sooner than normal. Men can have osteoporosis just like women can. It's just that women tend to have it more often than males. So let's take this individual who has a suboptimal lifestyle and are not very physically active. You can see that by 40 years, they've reached a level that's equivalent to what we would call osteoporotic. As opposed to this individual who had an optimal lifestyle, including optimal bone mineralization at a younger age, and they're going to reach the osteopenic level around 50. They're not going to reach osteoporotic levels until much later. So the age difference here where they reach osteopenia or osteoporosis is quite different. This has huge implications for being physically active as a young individual and then maintaining it as a lifestyle so that you can reduce the risks of that, because the impact or the impact of an early onset of bone demineralization can have devastating effects for the rest of your life. You don't want to be looking like this at 25 or at 30. And I have worked with athletes who have not had the appropriate or optimal activity levels, either because they've been very inactive or they've been excessively too active, or they have not been nourished properly, and they've experienced fractures at the femur, which you would never see in a 25 or 30-year-old normally. You would see that in an 80 or 85 or 90-year-old, and that's horrifying to see. So the impact is clear that being physically active is important. Well, what about the drugs that people take? Many of us, especially females, as we get into our osteoporotic years, we start to need to have some medications that will enhance our bone or maintain the maintenance of our bone mineral density. That's bone mineral density there, which also influences the geography or the microarchitecture of our bones. There are the bone drugs right there. There's many of them, and they impact bone mineral density. There, right there, you can see the graph. The figure shows us those arrows, and then the impact is that we're going to have less fractures. So many of us have to take some medication to do that. That's fine, and it does influence the risk of fractures by a little bit. But let's look on this side over here. What does exercise do for us? And this is going to be weight-bearing activity. Weight-bearing activity has all these influences. Not only do they influence bone density and bone geometry, which influences our risk of fracture, but it enhances our mobility and our physical function, our balance. It reduces the pain that we might have due to maybe a little bit of arthritis. It influences our health, from diabetes to cardiovascular disease to weight to the way we walk, our gait. And all those things are going to influence our fall risk. Bone drugs that are used to try to maintain bone mineralization, don't actively target fall risk, but exercise does, through its role that it has to play in here. So here's more evidence of how exercise can be used as a way to prevent fractures, to reduce the risks of falling. And falling, as you know, you must know, is that you fall at an older age and it's much more difficult to get up. And if you fall and you fracture at an older age, the impact of those fractures will be much greater to your overall health than if you were to have that fracture at a younger age. So we want to try to reduce fractures, reduce risk fall, and maintain bone mineral density for as long as possible in order to maintain quality of life. So this is a situation where being physically active with weight-bearing activities, and maybe you need to take some drugs, but doing that together is going to influence the bone health that you have. Well, let's look at some specific examples of exercise and how it does this. We have, this graph tells us about lumbar spine bone mineral density, and this is low intensity exercise, and this is moderate intensity exercise, and this is high intensity exercise or type that has impact on it. And this is in the improvement in bone mineral density over 8 weeks. And clearly you can see that with high intensity resistant exercise that has an impact to it. So that might involve some jumping, not high jumping, but leaping and landing. You're going to see a big, much greater increase in bone mineral density being maintained or even improved a little bit. This is a very busy graph or table, but what I want you to take away from it is the impact that drugs have on spine mineralization and femoral neck mineralization, and then the impact on fall risk. And what we can see here is the hashed lines are fall risk, and this is exercise over here. And while exercise itself doesn't provide a superior protection a superior increase in bone mineralization per se than any of the medications, and these are a whole bunch of medications that are typically used, especially in females, to help to prevent ongoing issues with osteoporosis. But what it does do is it has a much greater impact on preventing you from fractures. And this particular data comes from exercise work that did not include high intensity resistance and impact training. That involves weightlifting and jumping and leaping, bounding, that kind of thing. If they had added those numbers would have been even higher. So the takeaway message from this is that if you have to be on medications to deal with osteoporosis or deal with large bone loss at an older age, and you add exercise to your activity, you're going to reduce your risk of fractures. And you may not be able to regain all of your mineralization, but you're definitely going to help to maintain it. Let's shift gears a little bit and talk about diabetes for a minute. And the diabetes that I'm going to talk about here is type 2 diabetes as opposed to type 1. They're quite a different kind of disease, and type 2 diabetes is a kind of diabetes that is influenced a lot by lifestyle and can be managed very nicely with diet and exercise. Exercise plays a big role in being able to help us control our blood glucose levels, control our weight, control our heart disease, improve our blood pressure, and influence our stress. Okay, diabetes is a complex set of physiological actions that can have a very large impact on the quality of life and on our lifespan. What we want to be able to do is delay the onset of diabetes for as long as possible. We want to preserve the function of the pancreas, especially the beta cells that produce insulin, and we want to prevent the microvascular changes that come with diabetes that can end up causing great cardiovascular complications. As a matter of fact, those who have type 2 diabetes tend to be at much greater risk of hypertension and also tend to have 3 or more coexisting chronic conditions. The number one comorbidity is cardiovascular disease. And we already know that exercise has a big role to play in helping to reduce the risk of cardiovascular disease. And now we're going to talk about how it influences the development of diabetes, how we can reduce the risk of developing diabetes. And if we do have full-fledged diabetes, we can control its impact on the other comorbidities that are associated with it. We want to be able to improve glycemic control. And that's what we're going to talk about here. For this graph shows us a group of individuals that have impaired fasting glucose and those who have normal glycemia. And the takeaway message on this one is that those who have low fitness, here's low fitness is the lighter blue bar right here and right there. Low fitness normal glycemia versus low fitness impaired fasting glucose, which you would see in pre-diabetes or even in diabetes. Those that are moderate fitness levels have a lower rate of developing full-fledged diabetes. Those who have, and the same thing goes here. And those who have a higher level of fitness have an even lower risk of developing diabetes. And those that have a normal glycemia, they have the same impact. In other words, whether you have some impaired fasting glucose or not, if you have a better cardiorespiratory fitness, the risk of developing or the incidence of diabetes will be lower, which tells us that there's this tight relationship that exists between cardiovascular health and diabetes. Well, diabetes, as I said, is a complex disease that involves the pancreas. And here's the pancreas right here. It sits right in there, just below, tucked in just around your stomach, very close to your liver, which sits right there. And it has a group of cells in there that produce insulin and glucagon. The beta cells are the ones that we're focused on. And to make this really simple, if you eat something, your blood sugar goes up. And as a result, it stimulates the beta cells to release insulin, and the insulin goes off into your bloodstream, and it tells the cells that have the ability to take up glucose to do so. The liver is an example of that. Skeletal muscle is an example of that as well. And so insulin's job is to get that glucose out of the bloodstream and into those cells so that it can be stored, so that your blood glucose levels don't stay high after you've eaten something. They come back down to a normal homeostatic level. And sometimes it goes a little bit too low. And if that happens, then we have these cells that produce glucagon that balances it out. So we have this balancing act between insulin and glucagon. Now, where does diabetes come in is that with diabetes, the beta cells get fatigued, or they start not functioning quite as well, or the cells that respond to insulin stop being very responsive to insulin. So how do we manage to control this or repair this if we have cells like the liver or like skeletal muscle that aren't responsive to insulin anymore? Because if you don't have a response to insulin, the glucose stays in the blood and it stays high. And we want to try to get that back down. So this is one of the greatest examples of how exercise can actually change what happens in cells and improves general health and reduces the risk of a disease or improves the status of a disease without anything else. To be able to show you that, you need to know a little bit more about glucose transport. Glucose is a really large molecule. Here it is right here. And it can't get across the cell wall or across the membranes easily because it's so large. So it has to be carried across. And so that's called facilitated diffusion. And as it's carried across, it is carried across using receptors. It's carried across because of the activity of insulin binding to receptors and the activity of transporters that actually pick it up on the outside of the cell and bring it inside. Those transporters are called GLUTs, GLUT1s and GLUT4s. And GLUT4s are really very common in skeletal muscle and cardiac muscle, so I'm going to focus on that. because we're talking about exercise tonight, so that's skeletal muscle. So we'll talk about that. I like to use this picture of a Big Mac truck as being my GLUT4, and you see it's carrying sugar, and GLUT4s are responsible for taking up that glucose from the outside, pulling it out in the blood and bringing it into the body. Great. Well, the pathogenesis of type 2 diabetes involves an impaired insulin-induced glucose transport. That means the glucose transporters aren't working very well because they're not getting the message from insulin because the cells are not responsive to insulin. So you might have those GLUT4s, but you can't get the message to them. So how do we go about that? Well, this is how insulin functions. I tried to make, this is very homemade, but I think it works. So let's see. There's insulin right there, and there's the insulin receptors, and normally insulin binds to the receptors, and as a result, we get a cascade of events that happen that are mediated by a whole bunch of enzymes, and those enzymes create a situation where the GLUT4s that normally sit inside these vesicles inside the cell, inside our cells, that cascade of events leads to these GLUT4s being released from the vesicles, and they translocate or they move out to the edge of the cell. And as a result, they pick up the glucose that's on the outside of the cell, and they bring the glucose into the cell, and the glucose can be then stored in the form of glycogen, or it can be metabolized and provide fuel for the cell to do its work. But the result is that glucose is no longer in the blood. So blood glucose levels go down. Great, that's what insulin does. But in diabetes, in diabetes, sometimes that receptor, that insulin receptor complex doesn't work very well. And if those receptors are not very sensitive, then you're not going to get all this happening. No matter how much insulin you might produce, if the receptors aren't functioning properly, this is not going to occur. Well, let's look what happens with exercise. You might find this bizarre at first, but with exercise, when you exercise, insulin is blocked. We don't need insulin when we're exercising. In fact, we don't want it to be released because insulin's job is to get glucose out of the bloodstream and store it in all sorts of places like the liver. Well, if we're exercising, the muscle needs that glucose, not the liver. So if we use insulin, insulin's going to be storing glucose, and we don't want that to happen. So we're going to block the role of insulin altogether, which you might be thinking, well, if we block insulin, then we're not going to be able to get those GLUT4s to move. But in actual fact, we can, because exercise creates a cascade of events that are inside the cell that are very similar to that which we saw when insulin binds to receptors. There's a slight difference to it, but the end result is that those vesicles release the GLUT4s move out to the periphery of the cell, they translocate, they pick up glucose on the outside of the cell that's floating by, and the insulin ends up coming into the cell. Beautiful. We can use exercise to control blood glucose when insulin's not available or when the receptors don't work. So if you have a problem with your insulin receptors, you can still control blood glucose by being physically active. And the response to the exercise is immediate. It's not something that you're going to have to train for 8 weeks or 10 weeks or 12 weeks in order to finally get this. One exercise bout will do that. So one exercise bout every day will help you control your blood glucose, even when your insulin production is low or when your insulin receptors are not functioning very well. This means that the contraction activity of exercise, which causes all this change that occurs within the cell that allows for the GLUT4s to translocate and do their thing by bringing glucose back in, happens independent of insulin. That's a really important fact. And it's something that has led many others to follow the bouncing ball, that exercise can do this. What else can it do in our bodies? There are all sorts of mechanisms involved with this that we could talk about, but I'm not going to today. But I want you to know that we do know what those mechanisms are. Or we have a pretty good idea of what they are. And it's independent of insulin. You don't need to have it. So we can use regular physical activity to help control blood glucose levels in individuals that are completely healthy, or individuals that have prediabetes, or even those who have diabetes. Here's some examples of evidence of that we have 3 different exercise levels. This is leg glucose uptake, so how much glucose the leg muscles take up when you're cycling at a low intensity, at a moderate intensity, at a high intensity, and you can see that the harder you work, the more glucose you take up. Well, that must have something to do with the GLUT4s. Whoops, went the wrong way. And here is some evidence of that. This is GLUT4 translocation. You now know that the glutes have to move. They have to move to the periphery of the cell. That's called translocation. And the harder you work, the more translocation you have. And it doesn't matter whether or not you have diabetes or if you are healthy. Even those with type 2 diabetes, full-fledged diabetes, they're in the dark blue bars, they had an equal amount of response to the GLUT4s as those who were non-diabetic. So diabetes doesn't impact the GLUT4s so much, as diabetes impacts the receptors. The GLUT4s are there, you could still activate them, but you're gonna have to find another way. So the back door is to use exercise. Actually, I think that's the front door, but exercise plays a big role in that. But if you don't exercise, you're going to lose that impact as well. Regular exercise gives you more GLUT4s. We produce actually more of them. And if we don't exercise, we're going to start to lose them. And I use this just to show you that regular physical activity modifies the amount of GLUT4s you express, so the amount you have. And if you're inactive, you're going to start to lose them. So a 10-day holiday from being active means you're losing your GLUT4s. And if you lose them, you're not going to be as responsive. So if you're going to take a couple of days off of your regular activity pattern, then don't take too many off in a row. Throw one in every once in a while because the reduction happens very quickly. Doesn't matter what kind of activity you use. You could be using this is treadmill versus resistance bands. And what this tells us is that this is what your blood glucose might look like before the exercise. And when you finish exercise, your blood glucose is going to be down and it's going to stay down. And it doesn't really matter what kind of activity you use as long as you do something. Now, this is 30 minutes. It could also be 10 minutes. 2 minutes is probably not enough, but 10 is probably enough to get a little bit of response. 20 would be better, or 2 10-minute periods over the course of a day, or even better, 3 10-minute periods over the course of a day. Those of you who have diabetes or have been following along with somebody who you know that has diabetes might know that the HbA1cs, or the glycosylated blood cells, are something that the physicians follow quite a bit now, and more so than blood glucose. And exercise impacts this as well. So I'm not going to spend a lot of time talking about this other than to say that, yes, there's additional evidence to show that exercise can reduce your HbA1cs in a significant way. And a reduction of HbA1c by 1% is enough to reduce your risk of death because of diabetes, heart attacks, microvascular changes, or even amputations, because those with diabetes have a problem with blood flow to the periphery, and as a result, they often end up having to have toes, feet, legs amputated because of the lack of blood flow. So if we can use exercise to reduce HbA1cs, then we're going to have an impact on general health for a pretty significant way or manner. And here's an example of that. This is a 6-month training period. It's a large study, but I want you to notice that with a combined aerobic and a resistance exercise, you see this big decrease in HbA1cs. And that means that you're going to see a big improvement in quality of health. Okay, let's wrap this up with a few things to say about cancer. I've already gone a little bit longer than I thought. Cancer is something that we see quite a bit in our communities, unfortunately, and exercise can be used as an anti-cancer treatment itself to reduce the risks of developing cancer and all sorts of cancers. But more importantly, for today's presentation, it can reduce the symptoms of cancer if you have it. It can reduce the side effects of the treatment. And as you know, there are some pretty significant side effects to chemo and radiation. And it can improve the treatment efficacy. Yeah, that's what I mean, that you can use exercise to make the treatment actually work better. And we're only just starting to really learn the impact of that. Overall, regardless of the kind of cancer you have, you can get some kind of activity in there, even if you can't change the progression of the disease, you can improve the quality of life that you have remaining. Exercise has a role to play in reducing risk. It also has a role to play in enhancing anti-cancer methodology or treatments, and it has a chance of prolonging survival after exercise. Environmental factors and unhealthy lifestyle, like being inactive, plays a big role in increasing risk. Exercise is going to do the opposite. That's the focus that I want you to take away from this today. Very busy slide, but the story behind this is that if you can throw in some kind of weight-bearing or non-weight-bearing activity that provides mechanical stress, some metabolic stress, and an increase in blood flow, you're going to improve blood flow and blood vessel architecture. You're also going to increase, with this kind of activity, you're going to increase your immune system function, which also influences blood vessel architecture and blood flow. The net result, and that's what this is right here, that the tumor microenvironment, the effect of this angiogenesis that we have influences the delivery of medication. It influences the type of metastasis that a tumor might have. It increases, it reduces the amount of hypoxic environment, and that means lack of oxygen in an area. Tumor cells love hypoxic environments, but if we have a great blood flow into that region, we're actually going to reduce hypoxia and improve tissue oxygenation, which means that that tumor is not going to be able to function as well as it would function if it was hypoxic. So if we can reduce hypoxia in those tumors by increasing perfusion, we're going to reduce metastasis. That's spreading of the tumor. We're also going to, because of an increase in blood flow to that region, we're going to increase the drug concentration, so like the chemo drug concentration in that region, which means that you're going to become a little bit less drug or treatment resistant. It also means that your immune system is going to act a little bit more effectively as an anti-cancer agent itself. So I'm not saying that exercise can take the place of chemo treatments, but what this is saying is that exercise can enhance the treatment effectiveness. And that's big. It's so big that in some areas, they now have some cancer treatment facilities. They have fitness facilities right there where an individual will get their chemo treatment and then walk into the gym and do their workout right there and then, rather than go home and do it another time. It's a way of trying to enhance the effectiveness of the treatment. Now, not all treatments will work that way, but we do know that some do. And as a result, we get improved treatment delivery, reduced fatigue, reduced nausea, reduced side effects. We have a better tolerance to treatment, improved quality of life, and improved survival rate. Most individuals that are on an anti-cancer treatment can't actually follow the full treatment because of the side effects. So if we can reduce the side effects with exercise, the treatment will be more optimized. Another example, and the final example I'm going to use today, is that of prostate cancer, because prostate cancer, one type of prostate cancer is to use androgen deprivation therapy, which means that we're going to deprive the body of the androgens that are responsible for developing and maintaining muscle mass, bone density, and general function. What I'm really talking about is, I'm going to skip this, is testosterone. So it blocks the function or blocks the release of testosterone so that the cells that are the prostate cancer cells are deprived of that stimulus so that that disease can be managed a little bit better. The problem is that without testosterone, you see at net bone resorption. Remember we talked about resorption earlier? That means the osteoblast activity is lower, the resorption is higher, you're going to lose bone. Those men who are on androgen deprivation therapy for prostate cancer have a big risk of becoming osteopenic or maybe even osteoporotic. We don't want that to happen because while the prostate cancer may be treated, if you lose so much bone, your pathway through the last part of your life is not going to be quite as good as you want it to be. So we want to be able to manage that. Also, with a loss of testosterone is a loss of muscle mass. So the loss of strength, the increase in fatigue, the loss of function, the loss of bone means the side effects of the treatment are not very pleasant. And some of them are not recoverable. So we need to find a way to deal with these side effects. And one of them is to find a way to manage this bone loss. Well, in ADT or androgen deprivation treatments in prostate cancer, you can see a loss of 7 to 10% of bone a year. Well, menopause, we already know menopause is a huge loss, but in menopause, we see 1 to 3%. In those with ADT, prostate cancer patients with taking ADT, you're seeing much more bone loss. So you're thinking to yourself, I think by now, well, those men who are on ADT should be using exercise, and in fact, they should. Those that are losing bone and losing muscle because of their treatment, this is a cumulative fracture of those who are on ADT in prostate treatment, and this is a cumulative fracture in those who are not taking an androgen deprivation therapy. You can see if you're on androgen deprivation therapy, your risk of fractures is monstrous. So you better be doing some exercise, and particularly some resistance or some body weight kind of exercise, because if you don't, your bones are going to start to degenerate to the point where you won't be able to turn them around. And while the prostate cancer might be dealt with, the long-term side effects are very large. So you want to be able to get this kind of benefits, strength benefits, by adding strength training to your treatments. Otherwise, you're going to see this big loss in bone and a big loss in muscle that you probably won't be able to regain. So the exercise prescription is weight bearing, using mechanical stress like leaping, hopping, and jumping, not from high points because you're at risk already, but at low heights. So with prostate cancer, the benefit of exercise is that you can improve the tolerance to the treatment, and so you improve the response. You can improve your strength and your muscular endurance, your cardiovascular health, your weight's going to be managed, your anxiety and fatigue is going to be controlled, your confidence and optimism will probably be improved as well, and as a result, your quality of life is up there. So there's a whole bunch of different examples of how exercise can play a role in managing chronic disease, in preventing chronic disease, or in helping to treat it. Where do we get these exercise prescriptions? Well, as I mentioned before, the Canadian Society for Exercise Physiology does have guidelines. This is a guideline for those who are over 65. I chose that one. I could have chosen any of the other ones as well, but I guessed that this one works for me, so maybe it would work for you. So these are the numbers that I had mentioned to you before. If you're interested in these guidelines, which are used worldwide, by the way, you can do so by going to this website right here. The CSEP website provides all the guidelines for all age groups. And generally it is 150 minutes of moderate to vigorous activity in about a week. It doesn't have to be 150 minutes in a row. In fact, it shouldn't. It should be across most days of the week. So 30 minutes a day or something like that will work well. Strength activities, at least twice a week with most of the major muscle groups. Activities that enhance balance will be very helpful as well, and several hours of light activities, including standing. In other words, don't do your 30 minutes of exercise in a day and then think that the other 23 and a half hours can be just sitting around. They should be active as well. Where do you get this kind of information? Well, part of my role here at UVic and in the ILA medical program and with UBC medicine was to try to improve physician knowledge by helping medical students to learn a little bit more about exercise prescription, and hopefully we're getting that. Your physicians should be able to tell you about that. So you can ask your doctors about this. And there are many professionals, exercise professionals in our community. We're very fortunate to have some very great kinesiologists and physiotherapists that can do that as well. So search them out, because they will be able to provide you with really good exercise prescriptions so that you can take advantage of the role that exercise plays in helping to maintain your health, or to reduce your risk of certain diseases, or to help with the treatment of those diseases. So if exercise could be packed as a pill, it would be the single most widely prescribed and beneficial medicine we have. Would you not take that? It affects all of your medications. Unlike other medication, it can affect everything. So like they say in this cartoon, to treat your high blood pressure, diabetes, lymphedema, hyperlipidemia, osteoporosis, take this new pill every day. Take it out for a jog, take it to the gym, take it for a bike ride, because it provides you with so much more than all the different medications that you would need to take to do the same thing. The contraindications are very low. The impact is across our lifespan, and the result will be beneficial across all your physiological systems. The prescription is exercise. So thanks very much for joining me tonight. I'm sorry I went a little bit long. I get a little carried away on this, and I hope it was interesting to you. And if you have any questions, we have a few minutes for questions, so I'm open to that. Or you can email me at kgaul@uvic.ca. Thank you.
Great. Thank you so much, Kathy. That was fantastic. Like Kathy just said, we do have a few minutes for questions. So if you have any questions that you would like me to ask Kathy for you, please put them in the Q&A down at the bottom of your screen, and we'll get to as many of those as we can. I have a question for you, Kathy. So yeah. For somebody who's listening to this and feeling totally inspired, like I'm standing now in my desk, I was doing arm things as I was listening. For somebody who's listening and thinking, I really need to get started and doing more exercise, what would you recommend as the best way to get started and stick to it?
Good question. Start small. Don't aim high, or don't aim for something that is maybe going to make you so sore that you're not going to go back to it. Start small. Start by going for a walk, or going for a walk every day, a short walk or a long walk, or start by parking far away from the mall rather than right at the very front door, or doing the stairs instead of the elevator or the escalator. Start small and build from that. Join a group if you're so inclined, because if you have others doing it with you, it's a little bit more enjoyable for some than others. Choose something that you really like. Don't decide, well, the swimming pool is the closest place for me to work out, so I'm going to start swimming, but you really don't like swimming. So if you don't like swimming, don't choose swimming. I'll choose that because I'm a swimmer. Sure. So, but the same thing goes with running. It doesn't have to be running. Walking's so much better for you anyways. Choose something that you like to do, something that can fit into your timetable. Make time for it. You make time to check your emails. You make time to maybe look at your social media. Make time. It doesn't have to be a lot. As I said, it could be in little chunks of 10 or 15 minutes at a time. And make a commitment to yourself to follow it most days of the week. Not once a week. Once a week's not enough, but most days of the week, and make it manageable with the idea that you can increase it. Maybe every week you increase it by a little bit. If it's something that you have never tried before, then go to one of the rec centers where there are specialists who can help you learn how to do that. An example of that is I have friends who decided that they want to try dragon boating this summer, or they want to try paddling this summer, where there's all sorts of paddling groups in town. We're so fortunate about that, that will welcome new people in to try things out for the first time. And you never know whether or not you're going to like it until you try it. So choose something that seems interesting to you, not something that feels like a drag that you're just going to hate to do. Do something that seems interesting to you.
That sounds like good advice. Now, how fast and how long do you have to walk on a treadmill for optimum cardio?
How long and how fast?
Mm-hmm.
Well, again, it depends upon what your goals are. But if it's health goals as opposed to performance goals, something more than 10 minutes would be good. We're not talking about hours on end. Walking would be good. An incline is useful as opposed to flat. Put an incline on it, not a big steep one, but a little bit of an incline is better for your back to begin with, and a little bit of an incline just adds an additional challenge that increases the number of or the amount of large muscles that you use to do that. So something in the walking speed, which is different for different individuals, but your normal walking stride, maybe stride it out a little bit more. You want it to be at least 10 minutes, maybe 20 minutes. You might want to also change it up so that you start your first 5 minutes is a little bit slower, then into something that's a little bit faster. It doesn't have to be running. If you like to run, great. If you don't like to run, then walking is perfectly good. That means that you're not in flight. That means one foot's always on the treadmill, and you have a little bit of an incline. So you don't need to be running on the treadmill for an hour or an hour and a half to gain the benefits that I'm talking about here.
Oh, good.
Yeah.
Do you have a recommended heart rate beats per minute while doing aerobic activity for a 63-year-old? And also, does jogging count as weight-bearing exercise activity?
I'll start with the last one. Does jogging count? Absolutely. It counts because, one, it is weight-bearing, just like walking is weight-bearing. Swimming is not. Neither is cycling. But swimming is definitely not. It's good for you, but if you're using swimming as a way to help to maintain your bone mass, walk to the pool. Yeah. So yes, jogging absolutely, because you have that a bit of a pounding or a bit of a mechanical stress on bone. So it's good for you cardiovascularly, but it's also good for you from a muscle and from a bone perspective. Now, what was the first question again? I've already forgotten.
Recommended beats per minute while doing aerobic activity for a 63-year-old.
Okay, great. Well, you want to be working at an intensity, assuming you don't have any cardiovascular illnesses. You want to be working at something above 60% of your maximum and something below about 80 or 85% of your maximum. If you stay within that range, then you should be able to go for a long time. If you get up too high, you're not going to be able to last for as long. You may only last for 5 or 6 minutes, whereas if you keep it down below 80 or 85, 75, something like that, then you should be able to go for 30, 40, 50, 60 minutes without too much trouble. You should be able to still talk and walk, for example, or talk and jog, for example. So how do you get to that percentage? Well, you can predict. It's not perfect, but it's pretty reasonable to take 220 and subtract your age and the number that you have from that, find 60 to 80% of that number.
Oh, that's great. Thank you. Because I was going to ask if there was a chart. Yeah.
Yeah, that's it. It's about 80% of your age-related maximum heart rate. And if you don't know what your maximum heart rate is, then you can predict it by taking 220 and subtracting your age. As I said, it's not a perfect match, but it's close enough to be acceptable.
Okay, thank you. That's really helpful. Yeah. And the next question, if you have osteoporosis in your knee, is it still good to walk if you're feeling pain?
Good question. The literature suggests that if the pain is not so great that it's affecting your gait, so you're not limping along, but there's a little bit of pain, but it's not really changing your gait, then walking can actually enhance and improve the health of that joint. So in other words, yes, you can walk if you have a little bit of pain, but if the pain is so great that you are limping badly, then it's probably not a very good idea. Because if you're limping badly, if your gait's been affected, you are going to start seeing issues at your hip and at your ankle. And if you're doing that, you're going to start seeing it in your back and in your neck. So you need to be cautious about that.
Okay, that's good. And I've just added your formula for finding optimum BPM into the chat for anybody who wants to take a note of that.
Yeah, it would actually be 60 to 75 or 80%. I wouldn't go over 80. Yeah, make it over 60% and less than 80%.
Okay, 60 to 80%. There we go. Pumping that in. Why is it that walking is better than jogging?
You're more likely to do it for longer.
Oh, that's true.
Yeah. Also, jogging. You know, a lot of people don't jog well. They have a lot of extra movement happening, or a lot of wiggling going around, or you know, their gait isn't very healthy, so it puts a lot more stress on other joints. Also, there's a pounding that happens when you're jogging, and that can, well, there is some benefit to that. The mechanical stress on bone from that pounding is good. Too much of that pounding can actually be really bad, especially for older joints that are already starting to wear out. So
Right.
walking is a much safer activity to do than jogging, unless you're a really good, if you're a really good runner and you have really good joints. There's nothing stopping those people who have the bodies to do that, to continue to run well into their later years without any problem at all. We have lots of examples of that here in Victoria, but there are many of us that would like to continue to run, but it's not good. Yeah.
Okay. Well, I think that wraps up our questions very nicely. Thank you so much, Kathy, for this presentation. It was fascinating and interesting and inspiring. And I'm going to go home and be talking to my 2 teenage daughters about how important it is to make sure that they're getting all the exercise that they can during these years so that they can build up their bone bank for their adulthood.
You made my night by saying that, Leah, that I know that they don't tend to listen to all of us, but if that's the message that you've been able to pick up, and we can get that message out to our younger individuals, especially our adolescents, and especially our young females who tend not to do a lot of weight-bearing activity, who tend to not eat as well as they could, who tend to maybe drink a little bit too much pop, because pop and bone density don't go hand in hand,
Right.
Who work hard to try to keep the weight too low. And if the weight is too low, then you don't have challenges on bone. There's all sorts of reasons why we want to target our young adolescent females. Males too, don't forget them either, but our young women are at even greater risk.
Absolutely. So thank you so much. And thank you to all of you who joined in our audience tonight. It was wonderful to be able to share this evening with you. If you are able, please do join us for the last Masterminds lecture of the series next week with Dr. Patty Jean, better known as PJ Naylor, on physical literacy powered by environment. And this talk will introduce the concept of physical literacy and discuss why it's important across the lifespan, plus highlight ideas for physical literacy, supportive environments in our communities, and the implications of physical literacy for individuals. The link that you used tonight is great to use next week. And thanks again for joining us. Good night, everybody.
Thanks so much.
Thanks so much, Kathy. Good night.
Bye.